Hello everyone. Welcome again to the Borderline Personality Disorder Family and Consumer Education webinar. Today we're joined by Dr. Lois Choi-Kain, who's going to be speaking with us on compassion fatigue. So today's topic really focuses on caregivers, family members, parents, spouses, siblings, and others who are often torn about helping their loved one with borderline personality disorder and some of the challenges that it can present. Dr. Choi-Kain, for those of you who don't know, is director of the Adult Borderline Center and Training Institute and also medical and program director of the Gunderson Residence, which is a specialty residential treatment program for people suffering from borderline personality disorder, and both of those are here at McLean Hospital. She's also an assistant professor of psychiatry at Harvard Medical School. Before we get started, just a few of our usual logistical announcements for those of you who haven't joined a webinar before. All of your microphones have been muted in order to protect your identity. However, we do want this to be as interactive as possible. So in the lower right-hand screen, corner of your screen, you'll see a Q&A box. And right there you can type in questions, you can type in cases or conundrums that you're dealing with, and we will try to get through as many of those as we can. Additionally, there are a lot of resources for you in the lower left-hand corner of your screen. So the first three resources have a lot of information on borderline personality disorder and also referral information, because that's one common question that we get is, how do I find somebody who has expertise in borderline personality disorder near me? And those three resources in particular can be very helpful. The next link is to sign up for our next webinar, which will be later in June. And finally, all of these webinars are brought to you through a generous gift by a family who's been affected by borderline personality disorder. We make them free and available to everyone, but if you're in a position to help support these so that we can continue them, there's a link in that lower left-hand corner where you can click on and make a gift, large or small, to help support these webinars. And without further ado, I'm going to welcome to the webinar Dr. Lois Choi-Kain, who again will be speaking with us on compassion fatigue.
Hi everyone, it's nice to be here, and actually I can see some of the people who are in attendance, and I just want to say hello to everyone. I recognize some colleagues, some students, some staff that work with us, some families that have been involved with us, and a lot of other people out there that I just really thank for your interest in this topic. I'm no expert on the topic of compassion fatigue itself. It's just something that I've started to do more research and study of, because I've always been struck by the fact that the family members that we've worked with in our treatments at McLean Hospital have been through a lot of strain and oftentimes trauma from loving someone who has a disorder of such high vulnerability and such high self-destructive tendencies. So what we've been struck by in our work with families is that oftentimes the family members themselves come with vulnerabilities such as having experienced their own personal losses or traumatic experiences in the past, combined with the exhausting strain, stress, pain, and trauma of loving someone who has borderline personality disorder or its related problems. So I came upon this concept of compassion fatigue because it's something that relates both to the family members that we work with, but also the clinicians working with patients at large, but also particularly those working with patients with borderline personality disorder. It is known to be a high burnout situation for family members and for professionals, because the interpersonal demands and the emotional intensity of the work and the relationships with individuals with borderline personality disorder is so intense and severe. So this is what I will share with you today, which is what I know so far about compassion fatigue, and I will use my experiences and expertise in the treatment of borderline personality disorder to tie in how it's relevant to you all, either as professionals or family members or even patients who struggle with borderline personality disorder. So starting with just a basic definition of compassion fatigue, Dr. Charles Figley is a major figure in this literature. He is known to have developed the term and really advocated for its proliferation and study within the field of psychology. And what he first described compassion fatigue as is a state experienced by those helping people in distress in general. It is an extreme state of tension and preoccupation with the suffering of those being helped to the degree that it can create a secondary traumatic stress for the helper, whether you're a professional or a family member involved. And just to further break this down, I want to just allude to what it even means to be compassionate, because not all helpers or carers are compassionate. In fact, those who are less compassionate are in some ways protected from the strains of compassion fatigue. So just as a reminder, compassion itself is the process of feeling of deep sympathy and sorrow for another who is stricken by suffering or misfortune, accompanied by a strong desire to alleviate the pain or remove its cause, So one of the things to remember about this is not just recognizing that people need help. So professionals within helping careers like doctors, other health professionals, therapists, they may recognize intellectually that somebody needs help, diagnose the disorder, carry out the algorithm of interventions, but it's actually the compassion itself, the feeling of deep sympathy and the care emotionally of that person involved who's vulnerable that causes the compassion fatigue. And I'll explain more about that. So when Dr. Figley started writing about compassion fatigue, he actually interviewed a lot of health professionals. And there was actually a study of Harvard-trained physicians where they talked to a lot of these physicians about what it was like to be caring for a lot of people who are suffering. A lot of the studies on compassion fatigue are actually concentrated in the field of oncology, where the doctors, nurses, and other health profession staff are constantly and chronically dealing with end-of-life issues, serious loss, and really intense emotion. So what doctors had said, like this one author, is that as doctors, we all feel or have felt the distress and isolation. Ultimately, I believe there is no solution to the problem. All of us who attempt to heal the wounds of others will ourselves be wounded. It is, after all, inherent in this relationship. And what this speaks to, although it's specific to doctors, that doctors are affected by the work they do with the vulnerable, that is the patient, I think anyone who lives with, becomes a caretaker of, and cares about someone who's suffering from either an emotional problem or a physical illness, it takes a toll on them. There is a cost of caring, so to speak. And we'll discuss this at greater length throughout this seminar. So what is compassion fatigue? It is derived from both secondary trauma and a lack of caring for the carers. And what this picture depicts is what I call a victim of a marathon. This man has run a marathon and he has a medal around his neck, so there's some reward of it. But he just looks beaten down. His feet have bandages. He is just really unable to move. And oftentimes, those who are taking care of individuals who have prolonged illnesses or serious illnesses experience their caring as a kind of marathon that causes them injury. So to start with, in breaking down this concept, I want to talk a little bit more about what's meant by secondary trauma. I had mentioned in the introduction that what we found throughout the years of working closely with families of individuals who have borderline personality disorder is that they have a lot of risk factors for developing compassion fatigue. One risk factor being sometimes the history of having had their own trauma, either their own abuse as in early in life or as an adult, or their own losses of important caregivers. Secondarily, many family members have experienced suicide in their nuclear families or extended families that become sources of trauma. And then on top of that, when they have loved ones, like their children, going through suicidal episodes, it triggers a vulnerability that brings up memory of both of primary trauma and then the secondary trauma of being close to someone who experiences something overwhelmingly painful and out of control. So where this concept came from is the fact that Dr. Figley worked with a Vietnam War veteran very early on. In fact, Charles Figley was very active in protesting sending soldiers to the Vietnam War because he saw the effects on their psychological states after they came home. And he had this patient named Doc, who was a nurse in the military. And what he was struck by is the amount of guilt attached to not saving, helping more, or doing enough for some of the soldiers that this patient worked with as a nurse. And this struck me as very relevant to both clinicians, meaning clinicians and clinical staff, as well as family members who are often plagued with guilt at the degree of suffering that continues to go on for the individuals in treatment for borderline personality disorder or any psychiatric illness. So this experience that Doc had of this unending source of feeling like his efforts were inadequate and he was responsible for that suffering of those soldiers somehow, that seems very relevant to the experiences of those working with and caring for individuals with BPD. Around the same time that Dr. Figley was doing this work and thinking about secondary forms of trauma, the diagnosis of PTSD was developed and introduced into the field as well, and some of the diagnostic criteria really stipulated that this disorder could be applied not only to those who experience traumatic events, but witness those traumatic events in others. So the diagnosis itself back then included either being in harm's way or bearing distress of those in harm's way. And that included family, friends, and professionals working with the victims of trauma. And this can involve traumas that are not just one-time incidents or multiple incidents, but this can also involve chronic illness. Watching someone you really care about and spend a lot of time with suffer from a devastating chronic illness has a cost for the person that's caring. So what Dr. Figley wrote about this is that secondary traumatic stress is the natural consequent behaviors and emotions resulting from knowing about a traumatizing event experienced by a significant other. And what happens is there's stress resulting from helping or wanting to help that traumatized or suffering person. So compassion fatigue, which I'll sometimes refer to in the slides as CF, as shorthand, is a state of tension or preoccupation with the traumatized patient. And there may be in that carer or caring professional the exact same symptoms of PTSD as the person experiencing trauma. And those include re-experiencing of the traumatic event, that is like intrusive thoughts or nightmares about the traumatic situation, avoidance and numbing, and persistent arousal associated with that patient that has been traumatized. So that being said, there are different aspects and sources of compassion fatigue now that we've defined it. There's also the issue of burnout and countertransference. Now, countertransference is a concept I'm going to explain more in detail, but it's a concept we use with psychotherapeutic or mental health professionals, and it has to do with the relationship they develop with the patient. But first, I think the more familiar concept to everybody out there is the concept of burnout. And I chose this picture because that was really basically me at 4:30 in the morning finishing up my slides, is that anyone who just has a lot of demands on them experiences burnout sometimes. And what I've come to appreciate as a middle-aged person is that when you're trying to manage multiple demands in your life as a person with a occupation, whether that's outside of the home or in the home, plus raising a family, either taking care of small children or even simultaneously or alternatively taking care of ailing parents, and then the work of managing one's life on top of that. That in any situation can cause a large degree of burnout. And burnout is mostly driven from some elements of being really responsible and really caring about trying to meet the demands that are placed on your plate. So it's something that leads to a state of physical, emotional, and mental exhaustion caused by long-term involvement with emotionally demanding situations. So people who are in the medical profession oftentimes will experience high degrees of burnout because you have to spend your whole career day in and day out dealing with life-altering and sometimes life-altering and sometimes life-ending situations. But similarly, for family members of people who have these illnesses that medical or mental health professionals treat, the difficulty is that you don't go home from that job. You have that job 24 hours a day, 7 days a week, and 365 days a year. And that job that's more familial is hard to structure and put boundaries around. There's much more guilt associated with that. So whether it's burnout from a familial situation or a professional situation, that's just from the physical and emotional exhaustion, not from the caring, just from the doing. So burnout actually happens over time, as its kind of the term suggests. But the good news is burnout can have fast recovery from symptoms. So once you recognize you're burned out and you do something about it, you can actually get better from the condition of burnout pretty quickly. Now, the truth of burnout, too, though, when it comes from a professional situation, is that it may require that some people who experience professional burnout ultimately have to leave or modify their current job situation if they can't alleviate the symptoms in any satisfying way. Now, I spoke of this term countertransference. It's a much more technical term, so I'm going to explain it a little bit more. But countertransference is basically defined as the experience, that is the thoughts, feelings, urges, interpretations, desires, etc., of the clinician or the mental health professional in the face of the patient's usual interpersonal dynamics. So basically, all people who come into a therapeutic relationship bring to the table their style of relating to others. And some styles are more challenging than others. So some of the contributions to countertransference, that is how the clinician is feeling in the relationship with the patient, comes from the patient's dynamics and way of relating. But equally, some contribution comes from the clinician's own personal situation and history. And these experiences of countertransference are quick in onset. They usually have to do with interactions with or thinking about the patient at hand. And because it's a professionally bounded concept, the good news about this concept is that there's lots of techniques and concepts that we as professionals use to manage this experience of countertransference. So the technicality itself boundaries it and makes it more manageable, even when it's difficult. The interesting thing about this concept of countertransference is that in Charles Figley's writings about compassion fatigue, he actually cited an example of a patient who called him, who was actually a new therapist. And what the new therapist had called about was a request for therapy because her supervisor said that she wasn't doing a very effective job with one of the patients that she was assigned. And what happened in the course of this vignette that Charles Figley wrote about is that he finds out that this therapist that he calls Jane, so to speak, has a patient whose mother is dependent on her because of illness. And Jane, the therapist, keeps avoiding the topic that the patient needs to talk about. And upon deeper investigation, Dr. Figley finds out that Jane herself struggled with a mother dependent on her because of the medical illness. And the countertransference reaction really had to do with compassion fatigue. This therapist's compassion fatigue about her own personal situation that was emotionally draining and taxing affected her ability to support her patient who had the very same situation. So countertransference in general matters. Now, the interesting thing is that it may matter more in the treatment of borderline personality disorder. So we're going to go ahead. Just talking about a little diversion. These set of slides actually come from a different talk about countertransference that occurs specifically with people who have severe personality disorders. So there was a study done by Colley and his research group that looked at therapist experience of patients of different diagnoses in the personality realm. So those with paranoid, schizoid, schizotypal, antisocial, borderline, narcissistic personality, and so on. And what they did was really look at the kinds of experiences that therapists reported about these patients, basically their countertransference. So what I want to show you is that there's typical therapist responses to borderline patients. So for the borderline patient, what therapists reported, which I think is going to sound familiar to those of you who are professional mental health staff that work with borderline patients, but also it's going to be familiar to those of you who are family members. So what these therapists said was that they were overwhelmed by strong emotions and intense needs of the patient. They felt pulled into things, but did not realize it until after something happened or the session happened. They were frightened with high levels of anxiety, tension, and concern. They felt incompetent or inadequate with confusion and frustration in sessions. They were afraid they were failing to help these patients and sometimes felt guilty. See the definition of compassion fatigue. When they see the patient distressed or deteriorating, and they somehow feel responsible for that. Even when the patients are themselves doing things or making decisions that cause them this pain and stress. And then the clinicians go on to say they tend to treat the patients with borderline personality disorder as special, and they will stretch themselves to do things they would typically not do. Go the extra mile, make sacrifices that aren't sustainable or generalizable to their work with all patients. Now, I think a lot of you who have either worked with an individual with borderline personality disorder or really love a person with borderline personality disorder will feel that these experiences are familiar to you. And this is basically what we call countertransference. I also put in here, in addition, a description of the responses they had to patients who had narcissistic personality disorder and antisocial personality disorder, because these traits oftentimes coexist with the ones related to borderline personality. So for the narcissistic patients, therapists often said that they were bored, distracted, and annoyed in sessions, and what I find is that in my work with these patients, and also in my experience with family members, they oftentimes feel like they're very ignored or disconnected, disengaged, and just frustrated, feeling like they're not getting anywhere. The therapists and family members don't feel treated as an individual, and they feel like they're interchangeable with anyone else to the patient who can serve the patient's needs. And they end up feeling very ineffectual, invisible, and de-skilled, things that will lead to a sense of helplessness and burnout. And lastly, for the people who also have antisocial personality disorder traits, clinicians working with those patients or family members may often feel mistreated, criticized, or repulsed. They may feel intense anger or irritation, feel used and manipulated. That's also common to people who work with or love an individual with borderline personality disorder. They often feel that they themselves are being cruel, mean, aggressive, or punitive towards the patient for just giving them feedback or orienting them to reality. And they sometimes just really dread being around the person, wish they had never taken them on, wish they had nothing to do with them, which then sometimes generates feelings of guilt in the carer, that is clinician or family member. So these pieces of countertransference in themselves cause a lot of emotional burden on people who are either working with individuals with personality disorders professionally or with family members. So burnout plus countertransference converge to contribute to compassion fatigue. And I'll talk a little bit more about models of how compassion fatigue develops. But one important concept that I don't actually have mentioned on the slide is that a balancing leverage point to compassion fatigue is the opposite, which is called compassion satisfaction. Now, I bring this up after I've spoken about countertransference because there is a flavor of the countertransference reactions that we have with individuals who have severe personality disorders that make carers feel not satisfied or rewarded by their work because it's very uphill and challenging. It can be very exhausting, and it takes some time for the effort to be compassionate to feel like they yield the outcomes that are desired. Okay? So I will get back to the issue of compassion satisfaction in a second, but I just want to mention that it's not just about fatigue. It's about the absence of satisfaction. So how does this develop? Empathy and emotional energy are the foundation for working with the suffering and the vulnerable. Okay? So this is the kind of liability that we all carry in our work with patients in general in our field, but also when you care about something, you have empathy for them, and you invest emotional energy. That is like a good deed that's met with a cost to you. So even though empathy and emotional energy are the foundation of working with the suffering and the vulnerable, it comes at a cost to the carer. And because of this, we can break down things about carers that can predict the degree of vulnerability that carers have to compassion fatigue. So as I go through these, which are on the current slide, I want you to think about yourself, okay? Especially if you're a professional working with patients with borderline personality disorder or any patient, or if you're a family member, okay? So think about these factors. The first is empathic ability, the aptitude for noticing pain of others. So if you're actually a relatively focused person that might not be sensitive to the pain of others, and be able to kind of tune it out, you're less at risk for compassion fatigue. It's those who are more sensitive, observant, and empathic towards others who are suffering who are more likely to develop the problem of compassion fatigue. Empathic concern is slightly different. That has to do with the motivation to respond to the needs of others, okay? Because some people will just have empathic ability, see things that are sad, painful, or vulnerable in others, and they just feel with that person. They feel for that person. Now, people who, on top of that, have an empathic concern want to do something about it. It's almost like they can't help but do something about it. And they can't restrain their impulses to try to contribute. Another source of good deeds. Now, inverse to this is disengagement. So people who can disengage, you know, people who can be in their own little world and tune out problems that other people have are actually protected from having more significant compassion fatigue. So you may know certain people, like there may be certain people in your family who really care about your loved one with BPD, but they somehow can really disengage and like either have a good time or go to work and concentrate, and they can just let it go. And you, if you're a more empathically able and concerned individual, you may feel like really frustrated with that other family member who is so disengaged. But you have to recognize, too, there's something about that disengagement that may be preservative or sustaining for that person. So we can take a tip from that and really recognize that some degrees of being able to disengage or let go at times is really important to sustain your ability to support someone who's suffering. Prolonged exposure to a person that's suffering is also going to promote an ongoing sense of responsibility and maybe fuel unrealistic or untenable degrees of responsibility for situations that can't be changed, okay? And in addition, those who have traumatic recollections that are of their own and may be related to the loved one's suffering or just independent of that, they may have heightened vulnerability to compassion fatigue. Because being with, caring for a person who's experiencing a lot of pain and suffering, by definition may trigger feelings of helplessness or despair associated with past traumas, okay? And then what happens is this paradoxical thing where that carer gets activated in their own traumatic memories and simultaneously feels compelled to do something about it and tries to avoid at the same time. This undermines their capacity to actually be present enough in an effective way to fulfill their goal of being an effective carer. And that diminishes compassion satisfaction. Very complex phenomenon. And lastly, when you are taking care of someone who's really suffering in need and maybe completely unpredictable or predictably unpredictable, there are a lot of life disruptions. And the life disruptions, having to call out sick from work, change things around, make changes in plans to go some places, make changes in plans of how you're allocating your money and your finances, those life disruptions in themselves are an added source of stress. So all of these things can culminate in a model of developing compassion fatigue. So this was me in my burnout state at 4:30 in the morning. I was trying to figure out how to get this on a slide. And you can see my fingers. I just took a picture on my iPhone. So sorry about that little shadow in this diagram. But what you see there on the left is that there's empathic ability that meets exposure to a client who's suffering and empathic concern. This feeds into the helpful and expected empathic response we have to patients as professionals. You can also think of this in terms of family members. Your empathic ability combines with exposure to your loved one who has borderline personality disorder or some other severe mental illness, combined with your empathic concern, breeds an empathic response that takes emotional and physical energy that you spend there instead of somewhere else. Whether or not you get disengaged, if you can't turn it off, that can fuel more compassion stress. And if you don't have much satisfaction from taking care of that person, meaning it just doesn't seem to help, it's a drop in the bucket or only maintains that person instead of alleviating the source of pain, that leads to residual compassion stress, okay? Now that's just with one interaction. So if you see that this is a repetitive process and there's prolonged exposure that then brings up traumatic experiences that the caretaker has of their own, this fuels compassion fatigue. And then the last step of this is the degree of life disruptions that these empathic caring responses accumulate over time also weighs down a person that's taking care of someone who is sick in any way, but especially who's ailing from something like borderline personality disorder. So the way that you can take care of yourself around your vulnerability to compassion fatigue, because I think obviously you have vulnerability factors. If you're on this webinar, you care enough that you probably have some empathic concern and exposure to someone who's suffering. So what you need to do is identify early on those signs and symptoms of compassion fatigue yourself. Now that you know the risk factors or the factors that feed into compassion fatigue, you also need to know the symptoms. So this comes from an article that's actually on the compassionfatigue.org website, so you can look at it there. But just very simply put, you can probably guess what they are. You can probably relate to a lot of them. I think a lot of us can who are in the field, or a lot of us can who has ever taken care of someone with a serious illness. Exhaustion obviously occurs both from burnout and compassion fatigue. Reduced ability to feel sympathy or empathy, that's kind of the paradox of this, is that you care so much that you become numb and you stop being able to be spontaneous, genuine, and present. Some people start to feel anger and irritability. Also, ironically, while they're giving so much of themselves, they feel very angry and testy, and then oftentimes feel guilty about that. Of course, when people are stressed, they tend to have increased use of drugs or alcohol, and the boundary between normal uses of alcohol and problematic uses of alcohol is a very fine line. The truth of it is, it's not just a very small isolated part of the public who develops problems with substances or alcohol, but you see people rather easily tilt from a healthy use of alcohol into adding a few drinks a few days and then a few drinks every day to have a very problematic usage. And this over time contributes to a feeling of dis-ease, low energy, and less control over how one's functioning. Then also people will experience dread working with those patients or relatives that have these problems, where they're deeply vulnerable or highly traumatized. And then also carers start to feel guilty, like they're bad professionals or they're bad parents or they're bad children of ailing parents. They start to judge themselves. And of course, because they're feeling inadequate, they develop a diminished sense of enjoyment of either their job as caring professionals or their role as a mother, father, sister, brother, child, niece, nephew, aunt, uncle, so on. Okay? And so those things in life that are sources of satisfaction become very diminished. You feel more unskilled or de-skilled at them, and your life can start to become a downward spiral. And this all culminates into taking someone who is so well-meaning, so empathic, and so caring, so wanting to fix problems, to someone who's quite cynical and skeptical, as well as mistrusting. So compassion fatigue can make people feel alienated from all the things they started to actually purposely do with the person that's suffering or traumatized. You start out really caring a lot, but then you end up feeling jaded, angry, and alienated, which is really a horrible experience. The list goes on. There's also heightened anxiety or irrational fears. I find that with clinicians, staff, and family members alike, because the potentially bad outcomes are so scary and breed such feelings of helplessness and pain, they cause a generalized sense of heightened anxiety and irrational fears. It feels like the whole world is out of control when you're constantly feeling like your loved one will harm themselves and their lives or cause harm to others. This is also related to intrusive imagery of things that could happen because you're so scared about them, or imagery of things that have happened. Lots of family members and helping professionals have encountered scenes of situations where patients are either dying or have passed away, or their life is being threatened in some way, shape, or form, sometimes at their own hands. And that set of imagery related to those memories can become intrusive. Dissociation also occurs as a kind of psychologically protective mechanism. When someone's overwhelmed, they learn to kind of emotionally detach to insulate themselves from the overwhelming pain and fear of the situation. And then that dissociation generalizes to any stressful situation or any situation that poses a threat, a reminder, or a possibility of that very thing that's feared or traumatizing. There can be hypersensitivity or insensitivity to emotional material, and the fact that you can't predict or control whether or not you're going to feel hypersensitized or desensitized can be very scary and confusing. Difficulty separating work life from personal life can oftentimes happen for professionals in a caring profession. What we see in the medical world is that people work really long hours because some of the roles or positions that doctors have are not shift work. So in my days of training, I was oftentimes at the hospital until 1 a.m. and my attending was there too. So the fact that there is this way in which something more could be done causes people to work more than maybe is sustainable, and it causes feelings of guilt when they don't go above and beyond. So that work becomes life in general and then causes lots of problems in one's personal life. What this does in addition is that when people are doing so much at work and causing problems on the home front, they then avoid going home. And then they diminish another source of satisfaction that they can get from caring for others. Absenteeism, missing work, taking too many sick days, that can also happen to accumulate stress. And then all of these things cause impaired ability to make decisions and problems of intimacy and ability to receive support from others. So these are just some additional things that I'm not going to read, but you can see coming up. You can see these are related to some of the things we just talked about. And there's things that can make a bad situation of just feeling exhausted and spent from doing something that's really important to you to becoming a global problem about how you function and how you experience the world. So what do we do about this? So So there are some just basic tips on how to manage and treat compassion fatigue. The first step is just watching this webinar. The good news is you can go to the website compassionfatigue.org, read a lot more about it so that you can just have awareness of your vulnerability about your vulnerability to compassion fatigue and the different factors that feed into it. You can also desensitize yourself by just normalizing the fact that if you are to live with someone who has BPD, love them, take care of them in either a personal or professional way, you can just get used to it and practice some acceptance. But you also have to manage to expose yourself at intervals that are sustainable and predictable and vary those intervals with relaxation. You need to do things for yourself to restore your energy so that you can go back to being compassionate for someone who's suffering. This is where a lot of people will feel selfish for doing things that are self-care, but really you need to know that those things that you judge to be selfish are actually very generous to those you are caring for. And you really do need to also enhance your own social support. Oftentimes, family members and professionals feel isolated because they feel like they should do these things. That's their job, and they don't recognize their own need for care and support, the degree of care and support they're providing for their patients or their loved ones with serious mental illness, especially BPD. So the solutions to this, the path to wellness, is pretty generalized. You have to be kind to yourself. Take time for yourself. You have to enhance your awareness and educate yourself about the vulnerabilities that you have, not just focus on the vulnerabilities of your patients or your loved ones. You need to accept where you are at all times. Take an internal temperature. If you're struggling, if you're starting to realize that you're on that path to burnout, compassion fatigue, and really unmanageable countertransference, intervene early on. What some of the literature says is that you should rank different numbers for yourself. Just to simplify, take 1 to 5 and identify different levels of burnout for you, different levels of compassion fatigue. Meaning at 1, I might start to cancel all my social engagements, or I might start to work on the weekend. Or at a 3, I might just stop talking outside of work. At a 5, I might just be sleeping all the time that I'm not at work. So these are different things that you can recognize in yourself so that you know your level of vulnerability and intervene accordingly. Exchange information and feelings with people who can validate you. This is why in the professional world of psychotherapy, we have peer supervision, we get consultation. We support each other professionally and personally. And if you're a family member, you need support from other members of your social circle, your own family, your friends. And sometimes what I see in family members is that they're so busy taking care of their loved one with BPD that they just stop talking to family and friends because they don't know what to say, and sometimes they feel ashamed. Fifth, you have to clarify your own personal boundaries. What works for you and what doesn't? Now, this is particularly hard when working with someone who has BPD. Like I mentioned in the countertransference section, people with BPD have this uncanny skill to be able to push boundaries with others, to see what lengths to which they'll go to show their devotion, love, care, support, or understanding. And it's very important for both professionals and family members to have personal boundaries because this is going to prevent burnout and help you maintain some degree of control in a situation you can't control. Express your needs verbally and then take positive action to change your environment. You need to do things for yourself. It's actually not that likely that somebody is then going to turn around and take care of you in the same way you are taking care of your loved ones or your patients. Understand that those that are close to you may not be there when you need them most. And that's why you need to do a lot of things that are self-care oriented. So do things that are healthy. It's not rocket science like exercise, massage, and meditation. being able to do things where you let your mind rest from the worries and the suffering. Eat healthy food and drink plenty of water. That might sound really obvious, but it's the first thing that tends to happen when a unit has a crisis is people start refraining from eating meals and drinking water, and then they get exhausted more easily. I've had Joe Gold, the CMO of the hospital, advise our unit during hard times to make sure everyone drinks plenty of water, and that is something that really does promote well-being, and especially during stressful times. Practice the art of self-management, saying no when you need to, and not dwelling on the guilt you feel about saying so or judging yourself for saying so. Develop a healthy support system. Organize your life so that you can be on top of things rather than reactive. That's a real task for a family member of someone who has BPD, because your loved one may be so predictably unpredictable. But the more you set a behavioral schedule for yourself, like we ask the patients to do, the more grounded and anchored you're going to become, and the more rational it will feel to you to say no to certain things, because now it's time for me to do X, Y, and Z. And choose your battles. This is where disengagement comes in. One of the ways I survive is I really filter through the things that happen and come in front of me as things that I care about and things I either can't care about in the moment or can't do anything about. So you choose your battles. Even though everything's important in theory, you have to choose what you invest your emotional energy in. Okay. Now, how many minutes do I have left? 9. Okay. So I'll just go through this very quickly. The relevance to why this is important as a support or a carer of someone who has BPD is that what happens with compassion fatigue is that clinicians, other clinical professionals, and family members can vacillate in their availability, demeanor, and helpfulness with the person who has BPD, and that actually promotes their insecurity rather than alleviates it. So one of the things we know from research is that kids can actually delay their need to gratify impulses if they're in a reliable environment. If people around them do what they say they're going to do, they can actually be less impulsive. So your loved one can be less impulsive if you're more regulated and you're taking better care of yourself so that your efforts are more even though they may be more moderate. The ups and downs of heroism and then withdrawal are more problematic for people with BPD. Next, my next slide has to do with attachment. So in the models for the pathogenesis for BPD, insecure attachment interacts with biological traits that people acquire, like impulsive aggression or mood instability. And insecure attachment styles with BPD are characterized by these vacillations between good and bad, helpful and unhelpful. And what oftentimes fuels them is exhaustion in caretakers. Caretaker can be there and over-involved on some days and completely exhausted and unavailable to help on other days, just like I mentioned. And this feeds into the problems of unstable relationships, overvalued expectations of others. Their baseline becomes the heroism, and it's very easy to let down a person with BPD, and this feeds into their anxieties. So I'm just going to end with naming some resources that can support you as carers of those with BPD. They're listed here and they're down at the bottom. Just educating yourself is very helpful, but the additional support of using guidelines that help you feel more skilled, like the family guidelines that are listed on this slide, going slowly, keeping family environments cool, managing crises. These guidelines are available for free on the NEA BPD website. Are they on the website for the initiative too? No. But you can go to the NEA BPD website for that. And additionally, NEA BPD has a family connections program that is a very effective resource. I have gone to Family Connection Leader Training. I run Family Connections for people who are in the Gunderson programs, and I find it to be so relatable, so instructive, so effective, and it will really both make family members feel not alone, because it will really resonate with their experience, and make them feel more effective and empowered, and that can alleviate compassion fatigue. So that's it. That's a cake a patient bought us at the Gunderson residence when they were discharging and they were Gunder done. Thank you.
Thank you, Dr. Choi-Kain. That was a great presentation with a lot of very pragmatic and helpful hints. One thing that I wanted to just mention that I hadn't realized, you had mentioned the family guidelines, and those are actually available right in front of you on the right-hand side of your screen. About the middle, you'll see a download a list of resources, and if you click on that, the family guidelines are actually embedded in that, so you can download those right now. And we'll go ahead and get to some questions. So if people do have questions or are wondering how to apply some of the principles that Dr. Choi-Kain spoke about in her presentation, feel free to type them in. The first one is actually a pretty common question that we get, but I'll see what you have to say. So my daughter, who has borderline personality disorder, is purposely avoiding me. What do you recommend when somebody's pushing you away? Should I push to see her? Do I just wait until she makes an effort? And I think one of the common challenges is you talked about the intensity of the relationship, and also the pushing and testing to see, do you care about me? Do you love me? And if you just let go, I think a lot of parents and other people are terrified that she or he will feel abandoned and you don't care. And yet every time you approach and say, do you want to talk? No, I hate you, leave me alone. And any recommendations for parents or other loved ones?
Absolutely. I think this is, just to tie it into the concept of compassion fatigue, that intense oscillation between the push and the pull, the need and then the mistrust is exhausting. When you care about someone and they're pushing you away and they clearly need you, that can take a toll. So what I'd say to kind of weave in the tips I've given you is trying to take a moderate approach and do something that you can live with, meaning that you intermittently make clear that you want to be in contact, that you're available, that you love your daughter, but not expending too much energy to make it happen if it's not working. You do what you can, be consistent, maybe send an email or a text or call like once a week, something like that. And don't withdraw necessarily unless they say something like, give me space, and if they're in a safe place, that may be your only option. But when you try to do your best at doing what your values would dictate you do, and don't put yourself in a situation where you feel unduly helpless or responsible when you can't really do anything, that will be the best for preserving your energies in the long run to managing your relationship with your daughter with BPD.
Great. Another person asks how you can get support as a single parent of a child with borderline personality disorder and also some physical problems like Lyme disease and others. This person says it's very difficult to find a peer group. Do you have any recommendations for people who are out in rural areas or where maybe there's not a live family connections group? What can they do?
That situation is very difficult and common. People who have borderline personality disorder tend to be very physiologically sensitive and oftentimes have real significant medical illnesses. And the combination of the BPD plus the medical problems can be a lot for anybody to handle, especially when you're the sole caregiver. There are some resources like the Personality Disorder Awareness Network, which is more of a peer-run like kind of a texting support. I know that's not as satisfying or as robust as an in-person group, but that's available. I think it's a very good association. It's oftentimes geared towards parents who may suffer with some of their own vulnerabilities, and it provides some resources in addition to the ones we've illustrated here. In addition, Family Connections is oftentimes led over the phone, in addition to being led in some locales in person, and doing us on the phone course of Family Connections is better than nothing. But just getting peer support, taking breaks, having people in your community give you the opportunity to do something for yourself from time to time. That may sound like a tall order, but is something that I'd advise you to try.
Okay, and I think we have time for just one last question. And this, again, is a frequent question that comes up in a lot of our different webinars. So we have a 30-year-old daughter who, by everything that we can cipher, has borderline personality disorder. She sees a therapist, but the therapist doesn't talk about borderline personality disorder. Nobody has used that label. Nobody, and it seems to be a taboo subject that nobody wants to bring up. Do you have any specific, this person asks a very clear question, do you think I should tell her? Should I bring up that word, that label, and talk about it, or is that ill-advised?
I think I tend to tilt in favor of talking about the diagnosis. A lot of people are worried about providing a diagnosis because they don't actually have resources or training to manage what comes of it. So clinicians themselves may avoid it, but if you as a family member are concerned and feel that it's a relevant diagnosis for your loved one, just bringing up that you've been doing some reading and this is something that really resonates with you, and you're really just trying to be helpful and find something that allows you as a family to be more supportive and more understanding of the problems and might allow the patient to get more effective help. If you phrase it in that way, it can be received better. But of course, some of the symptoms of borderline personality disorder, the reactivity, the intense anger, the reckless behavior, that does bring up understandable fears about even talking about any difficult subject, let alone the diagnosis. So I feel that sometimes just broaching difficult topics in general is just advised because you're going to have to do it, including the topic of the diagnosis. And she may reject it, but at least you know you tried.
So with that, we're going to have to end today's webinar. I want to remind everyone our next webinar is Thursday, June 29th. You can register for it right on your screen in front of you if you click on that link. And I want to thank Dr. Lois Choi-Kain again for a great presentation. And until our next webinar, good day.
Thank you very much for listening.